Hey, we're back. We're
Hey,
recording our next episode of Blood Matters, a podcast for nurses. How are you feeling?
Feeling great, Emma. Thanks very much. Yeah, really delighted with the response so far to the podcast. It's been a really exciting few weeks, few months, lots of amazing topics. So absolutely delighted.
Yeah, I'm really excited for some of the topics we've got coming up. Although last time we recorded, I was just blown away with our guests. I think they were such a fantastic team. So long may that continue with our future guests. So this week we're talking about myeloma.
We are indeed, absolutely. And what a fascinating subject myeloma has become in the last, well, I mean, in the last decade, I think, really, but particularly exciting in the last couple of years. And so excited to hear what our guests might have to say about what might be happening with myeloma in 2023 and beyond.
Yeah, we're not going to spoil it for you guys, but absolutely excited to hear what our guests have to say. It's really exciting to talk about where myeloma is going, because as you say, the last decade has changed, but the last couple of years has blown up. And well, we're not going to tell you the stuff. The podcast guests are going to tell you the exciting news. And I think that we are going to have a really good conversation with them today, actually, based on who we've got. So I guess we can probably say now that we've got Graham Jackson from Newcastle, and we have got Maaike de Ruijter from the Netherlands. And I apologize, Maaike, if I've messed that up. When we introduce you properly, I'll re-apologize, hopefully get your pronunciation correctly. But we've got our second international guest as well from us, because we're obviously based in the UK.
Yeah, no, it's super exciting. And this time we have a doctor-nurse combo as well. So it'll be really good, I think, to hear the differences in experience, differences in ideas around what might be happening in the future, and differences in the changes that they bring to patient care.
Yeah, absolutely. I'm really intrigued to hear what happens in the Netherlands and see if there's anything that's different in the UK, and maybe then different for our listeners elsewhere in the rest of the world, and maybe some ideas that we can take to our own centres and say, hey, I heard this thing on a podcast. Maybe we should try this.
Yeah.
Which is my hope for the podcast anyways, to get ideas going and out and around and about.
No, I mean, I'm especially excited, as Graham will be our first ever speaker who is now representing a third sector organisation. So he now works for a charity, dedicated to the field of myeloma. And I think that brings us a new perspective to the podcast.
Absolutely. And I think we are able to have a bit of a voice here about what third sector can do for our patients, but also for our colleagues, and that we don't always get in touch with third sector, or we don't always have those conversations with third sector. I don't know why personally, but I know that is something that sometimes we kind of don't always, we point patients at third sector, but we forget about what they can do for us in terms of education and learning. So I'm really excited to hear Graham today as well.
And absolutely. By third sector, we mean kind of charitable organizations, and those organizations that exist outside of the kind of conventional health service area, directly delivering healthcare. But third sector organizations like charities, they provide, a really pivotal structure for patients and healthcare professionals in terms of, there's a lot of work going on in charitable organizations in terms of research, patient support, and patient information. That we are all well served to take advantage of. So I think, those organizations exist throughout Europe. They are often country specific. So again, during the podcast, it'd be great to have people think about what third sector organizations, what charitable organizations exist in your countries, and how you may best take advantage of the support that they have to offer you in delivering patient care, and also that they have to deliver your patients directly.
And actually, guys, if there's anyone that you think we should be inviting onto the podcast in terms of third sector from around the world, drop us a line and we will have a look into that and see if we can link it up to one of our future topics. But we're very keen that this podcast is led by you in terms of what you want to know about, as well as by what we want to interview people about, because we're excited and we love this. So absolutely, let us know in the usual manner.
So I think we're nearly time to go, aren't we?
I think we are. I think we should be getting our guests on imminently, introducing them and double checking that I haven't butchered anybody's name today, which may be the situation. Maybe. Really excited to say that this week we are going to be discussing myeloma, and we are joined by the lovely Graham Jackson from Newcastle in the UK. And we've also got Maaike de Ruijter, who is from the Amsterdam UMC, which funnily enough is in Amsterdam. Graham is a consultant hematologist and Maaike is a nurse practitioner. And we are going to spend just the next bit of your time having a chat through myeloma and sort of the changing face of myeloma over what we hope is 2023 and beyond, and maybe how it's a little different to how it's been in the past. As ever, I'm also joined by my lovely co-host, Michelle. Hi, Michelle. How are we doing?
Hi, Emma. Hi, everybody. So great to see you. So great to hear you. Really looking forward to the next 40 minutes or so.
So we're changing up the format a little bit this week, guys. Instead of me interviewing one guest and then Michelle interviewing the other, we're going to change it up. We're going to see how it flows this time around. So please give us your feedback. If you like it this way, let us know if that is how you prefer us to present the podcast. Our first guest, as I say, is going to be Graham Jackson from Newcastle in the UK. And I'm going to let Michelle take the lead on the first question here. And then we'll all have a chat. But welcome to the podcast, Graham. Thank you for joining us.
It's great to be here.
And hi, Graham. First of all, I wanted to say huge congratulations on your new position, your new role. So you are a consultant hematologist and have worked in the field for a number of years and are very, very well known for the work that you've done. But you now have a new job as well as a chief clinical and scientific advisor for Myeloma UK. Can you tell us a little bit about that new role and what your aspirations are for that?
Okay, Michelle. Well, as you know, I've always been a passionate believer in patient information, and Myeloma UK is a great organisation. For those of you watching this and don't know it, it really concentrates on giving information to the patients. And as I'm sure all of us know, that the best weapon our patients have against some of the fears is having as much information as they can. So we've got paper information, online information, there's a telephone helpline, there's newsletters. And I guess my job is, one of the jobs is to make sure that information is up to date and as useful as it can possibly be. Also, it's to help direct research strategy. We have a big investment in the Marsden and the ICR in terms of cytogenetics. I think Myeloma UK has a great role in advocacy, as we know, and there are many new treatments in multiple myeloma, and it's our job to get those treatments to our patients as quickly as we can and to monitor their safety. I think one of the other roles Myeloma UK has had is looking at myeloma delivery and clinics and looked at levels of excellence. And we know, and a great shout out, that actually the biggest improvement in myeloma care, I would say, across Europe and certainly in the UK, is the advent of brilliant nurse specialists. And we are very blessed, as many centres are, to have fantastic nurse specialists. And if there's one innovation over the last 20 years that I would applaud more than any, it's that allowance of great skilled medical and nursing teams to work together and complement each other. And I guess the other role is that myeloma is a disease that is responding really, really well to treatment. But one of the key areas, it's still diagnosed too late. And many patients come to us, as you will all know, with too much bone disease, too much renal problems. And so we've got to get our patients to our clinics where we can treat them really, really well with as little bone disease and as little kidney damage as we possibly can.
It's so exciting. Actually, you're the first guest that we've had that actually works with a third sector group, and we want to explore that a little bit further. And so I was actually going to ask you, how do third sector groups maybe help their patients directly and indirectly, and nurses? Michelle and I discussed before you guys came on how we felt that, well, certainly I feel that we as practitioners, we can sometimes underutilize the third sector. So sort of to take it a bit further into what you're saying, what else can the third sector offer to patients directly and indirectly?
I think that one of the things we all know in the age of the internet is that patients will seek information outside of clinic and outside of clinical practitioners, be they doctors or nurses. And so I think the third sector can really offer trusted information that the patients can access in their own homes and read in their own time. And one of the things that I've always done is signpost patients to that information, because it's written by people who know the disease, it's trusted, and there's so much misinformation out there that you want to make sure your patient gets to information that is verified, is true, and doesn't contain misinformation that might mislead the patient about treatments.
I love that term. Trusted is exactly what it is. It needs to be trusted. We all know that search engines can lead you to the worst of the worst scenarios and actually scare the patients away from treatment on occasion. So I agree. Trusted is the term. I like that a lot. Thanks, Graham. Michelle's got the next question for you though.
Yeah, I agree completely with that sentiment about information and about trust. So important. Graham, I'd like to hear about some of the research that you've led to date, kind of slightly switching up a little bit, and particularly interested in myeloma drug resistance. So taking it right from that, away from that sort of early and prompt diagnosis, right the way along the line to drug resistance.
Yeah, obviously, we know that myeloma patients respond really well to a number of therapies, Michelle, don't we? And we very much moved to continuous therapy in multiple myeloma. But the inevitable consequence of that is that the disease becomes resistant to the treatments we're using. So I think one of the things that we've kind of looked at is pioneering triple and quadruplet therapy, so that the myeloma cell has to develop resistance to 4 different drug pathways, and therefore the chances of that happening are less. I think we've also been concerned, and one of our great areas of research in myeloma trials in the UK has been Revlimid maintenance, and that has generally been to progression. But one of the problems with treating patients to progression with Revlimid maintenance is they inevitably become Revlimid resistant. And we know the outcomes of that are less good once those patients go on to further therapy. So we're really been exploring whether we can limit the duration of Revlimid maintenance without losing any of the efficacy. We've also pioneered treatment for high-risk disease through an Optimum study, which was a transplant for transplant-eligible patients, looking at how we hit the most genetically abnormal myeloma the hardest to try and improve outcomes. And I think one of the other issues around, it's not necessarily resistance, but it's around tolerability. And we know that myeloma is a disease of the elderly. And I think one of the issues is that treatment won't work if patients don't tolerate it or don't receive it. And we know that our elderly patients have a higher number of side effects, they tolerate treatment less well. And so we've really started to focus on the older, frailer patient and seeing how we can deliver therapy safely to that group of patients too.
Thanks, Graham. I mean, we see one of the kind of rate limiting steps for myeloma patients in terms of treatment is the development of peripheral neuropathy. I can't even say it. And I, that has a really significant impact on people longer term. I guess we can pick this up a bit later on in the kind of quick fire questions, but any sort of thoughts you want to share around that and how that might compromise treatment for patients?
I think, Michelle, that's such a good point. I think any of us who treat patients with multiple myeloma know that peripheral neuropathy is one of those symptoms and signs that are really difficult to treat. They are significantly impactful on patients' quality of life in a negative way and often linger for not just months, but years. So I think one of the things we have to look at is how we deliver treatment safely. One of the things that we know is that the combination of Velcade and thalidomide is particularly neurotoxic. And so in my role in Myeloma UK, we're really advocating that we switch from thalidomide to Revlimid, not necessarily because of efficacy, but just to reduce the legacy of treatment in terms of peripheral neuropathy.
Yeah, great. Thank you so much, Graham. Back to you, Emma.
Thank you. I was just thinking away as you were saying that, Graham, is that actually I think that sometimes peripheral neuropathy, see, I can't say it either, Michelle, is an underestimated sign and symptom for our patients. Although we want to know about it, I feel sometimes they can underreport it because they don't want us to stop treatment, or they don't want us to mess around with what they think is working. So difficult one, but I'm really interested in what the future holds with that. And speaking of the future, as a group here, I think we all kind of have our expectation about what maybe is on the myeloma horizon in terms of treating and research in Europe. But could you maybe give us a little breakdown of that? You know, in there somewhere I'm trying to say CAR T cells, but also what else might there be there? I love that Mike is grinning away at that. We'll talk. But what else do you think is maybe on the horizon for us, Graham, that we can offer our patients, especially those who may struggle with treatment toxicities?
Well, I'm looking forward to hearing Maaike as well. We know that the field of myeloma, the advent of a number of new therapeutic avenues is really dramatic. And you've mentioned CAR T cell therapy, and we know that CAR T cell therapy has the highest response rates that we've ever seen in multiple myeloma. We've seen from the Cartitude studies and the Chalmers studies that ide-cel and cilta-cel are amazing therapeutic breakthroughs. I think probably one of the difficulties we're going to see through Europe is how we make these treatments available. There's issues around affordability. There is issues still around slots and manufacturing capacity, because all of these products are manufactured in the United States. So that's an issue at the moment, which I think will be solved over 2 or 3 years. But I think although we're anticipating CAR T cells being part of our treatment strategy, there are some logistic reasons why it may take longer than we want it to.
Yeah.
We are also lucky that there's drugs called T-cell engagers, which are equally exciting. These are drugs that really involve the immune system without the transplant, but they have the same targets, BCMA, amongst others. And these are given subcutaneously. They're continuous treatment as opposed to the once-off therapy of a CAR T-cell treatment. And they have some of the similar toxicities, but these are becoming readily available on named patient basis. I think they possibly be able to be given more widely than in a CAR T-cell transplant center. But clearly, there is still a problem around the adverse effects like CRS and ICANS that we cannot and must not ignore. And then there are other drugs. We talked about Revlimid resistance. We've seen Revlimid was developed from thalidomide, and pomalidomide was developed after Revlimid. And there's 2 drugs that can really overcome it. We were talking about Revlimid resistance. There's a drug called iberdomide and mezigdomide, which can work when patients become Revlimid resistant or pomalidomide resistant. So there's a lot of exciting activity in multiple myeloma, Emma, and I think we will see a lot of these treatments come through in the next 2 to 3 years and continue to build on the success we've seen in terms of myeloma treatment over the last 20 years. One final thing is that we've just seen the determination study in terms of EBMT. We've seen that stem cell transplant in first remission still seems to be an important part of treatment. So one thing I think we won't see change over the next 2 or 3 years is we won't see autologous stem cell transplant fall by the wayside. I think it's still an important part of treatment paradigm in myeloma.
Fabulous, which gives us continually a podcast to talk about, Michelle, because we're going to still be talking about transplants. For those that don't know me particularly well, just going to say CAR T is the thing that I geek out over the most. I'm very excited for it, but I love the fact that myeloma hasn't been left behind as such in terms of a disease group, because there's obviously been so much push towards these novel agents in terms of lymphoma, and obviously lots of research in terms of leukemias, but we haven't forgotten about our myeloma patients. I think that's great. Graham, thanks for the chat. Stay with us. We're going to pull you back for the quick fire round. I'm going to pass it back over to Michelle to introduce Maaike again, and for us to have a chat with Maaike and sort of see how things are over in Amsterdam, where we will hopefully be making some of these CAR T products closer than the USA at least. So Michelle, all yours.
Hi, Maaike. Welcome. Once again. So Maaike, you're working as a nurse practitioner in Amsterdam, and you're a member of the Chronic Malignancy Working Party of the EBMT. Just want to ask you, what is it that you enjoy about having a nurse role in that working party?
Thank you, Michelle, for your nice welcome. I'm very pleased to be here and to enjoy this session. As a nurse, I'm always looking for opportunities to educate nurses. So as a VP nurse, I get a great chance to organize educational meetings for nurses and nurse practitioners. So that's a big part of my activities as a VP nurse. And what I also really love is to be part of a team of professionals who are very driven to take education and research to a higher level. And they do it as a team. So I'm really enjoying being a member of the Chronic Malignancy Working Party.
Thanks, Maaike. Because the Chronic Malignancy Working Party, it's a kind of a real get together of all of the chronic malignancies. So you have in there the CLL and myelofibrosis, together with things like myeloma, which kind of brings together a whole load of different minds and mentalities around chronic malignancy, because of course they all behave in quite different way, affecting different lineages, like different patient populations, and very different treatments in the most part. So it must be great to be in that room and hear all of that stuff.
Yeah, it is.
Be quite exciting. And then when
every meeting is exciting. Yeah.
And then where there is, commonality, again, kind of learning from each other and the experiences that you have. So it must be really exciting.
Yeah, it is, and that's why I think it's important to join the nurses in those meetings, because I think there is a lot we can learn from each other, and nurses to physicians and physicians to nurses and so on. So I think it's we have a big role as a nurse in those groups to have combination sessions with physicians and nurses.
For those of you who are listening, you won't be able to see Graham also nodding at this, who is a massive advocate, as he's already said, for interprofessional working and what that brings to benefit patient care. I'm just going to hand back over to Emma now.
You took half the words out of my mouth, to be honest, Maaike. I was about to say, guys, get involved with your working parties. It's something we like to talk about. Certainly from episode 1, where we were saying to folk that you can go to any working party as a nurse. You have a voice, and it's this linking working, isn't it, that makes the big difference for the patients. So congratulations on the lead nurse for the working party as well. That's quite a recent thing for yourself, I think. So beyond the education events that you're putting on, what other things have you been doing, certainly in the working party, and then even since you became the lead nurse? What else have you been up to? What can we entice our nurses to come along and do with you?
I just started up the role of the lead nurse, so there is happening a lot in the last month, but we are starting now to try to organize a meeting during the annual meeting in Paris to meet all the VP nurses and to talk about our experiences and sometimes challenges maybe that we have, and to look how we can work together and learn from each other. So it's just starting up, but I think we can do a lot together, and looking for combination sessions with our working party groups, like the cellular group and the chronic malignancy group, trying to organize a session together. So I think it's a start, and I think it will be promising.
It sounds like, and you're right, nothing sits in isolation in terms of hematology, does it? We don't all kind of sit in our little bubble and never speak to the other groups and never speak to the other parties. So absolutely, that link together sounds fantastic. And we don't know if this episode will have been put out before or after annual conference at Paris, but I will hope that meeting, that link together does work and starts some even more interesting conversations. I'm going to pass you back over to Michelle for the next question. We'll probably bring it down to a bit of myeloma. That's what we brought you here for.
So I'm going to ask you straight out, what is it about myeloma and the field of myeloma that inspires you as a nurse, Maaike?
First, I think it's that there is a lot of new therapy options for in the myeloma fields. So that's exciting. But because of that, the patients need more and more support, because therapy isn't just for a few months. It's getting more and more like a chronic disease with lots of therapy, and it's not only the patients that is involved, but also the family that is around the patients. So as a nurse, we can be a very important role in educating about the new therapy, but also to be there for the patients and to be there for the caregivers. So that it's very exciting to be a part of the treatment team for these patients, and I think all patients with multiple myeloma need to see a nurse, not only
Absolutely.
when they are admitted, but also when they are at the outpatient clinic.
Completely agree.
Yeah,
there's a whole lot of nodding in this room, in this virtual room at the minute from all of us.
Yeah. It's when you know your patients, you also find a way to find out what is the right therapy for your patients, because there are so many possibilities there are so many treatment options, and sometimes you can choose which treatment option is the best for the patients, but you can only do that when you know the patients. What is important for the patients? What do they like? Do they want to stay more at home, or do they feel safer to receive treatment at the hospital? And I think we, as a nurse, we can find that out better than a physician, I think.
Contentious, Graham.
Sorry, Graham. Sorry.
Not for me. No, I agree.
Yep.
I think Maaike, there's also something that we do as nurses in understanding what the support structure and infrastructure is for those patients, which is often a background to why our patients make the decisions that they do around treatment, and whether there is anything that we can do to support the family unit during treatment, to enable a range of treatments to be more accessible and more manageable.
Yeah, exactly. Yeah. And I think another challenge of all those new therapies is that patients treatment changes are sometimes in a year several ways. So when patients meet each other, they say, hey, my neighbor sitting here at the daycare gets another treatment than I get. Why? So I think because all that goes so quickly, it's important to inform your patients about the treatment option and why is it changing. And that the treatments they are receiving isn't the last treatment option, because a lot of patients think that this is the only treatment there is for them. Yeah. So you always need to talk about your patients and the patient's fears they have, or challenges they feel about receiving the treatment.
And that leads us very nicely into Emma's next question.
It really does, actually. It really does. So Maaike, I know that you're extremely passionate about quality of life in our patient group, and then particularly myeloma patients and patients that have received a transplant for their myeloma. Are there any things that you think that we could be doing to offer even better support? Is there anything that you would change?
I think we need to look at quality of life of our patients, to talk about it. A lot of patients are feeling a distress, and distress could be feeling like depression, anxiety, sometimes panic. They also can feel a social isolation, especially during the last COVID episode. So it's very important that have our attention, and we discuss it with patients, and not only discuss it, but also help patients for a way they can support the problems. So refer to physical therapy, or refer to support in the neighborhood. It's very important that we do that as a nurse. And also, we already talked about it, the neuropathy issues patients has. I have a great experience with duloxetine, but we need to start it early in the treatment. It happens a lot that patients don't talk about it, so we need to ask about it, and tell them that sometimes it's better to reduce the treatment than continuing and suffer severe neuropathy. We need to tell them that it's safe to do a dose reduction.
Yeah, we need our patients to feel comfortable to tell us.
To tell it, yeah.
So that they're not worried about it affecting
the
consequences. Absolutely. Yeah, absolutely. So it's about that relationship, and about that. Well, as both of you have said, Graham and Maaike, you've said about having that nurse contact, that nurse specialist or repeated person who knows the patient. Michelle's got a last question for you, Maaike, before we move on to the quick fire round. So I'll pass back over to Michelle again.
Thanks, Emma. So again, takes us really nicely, I think, into what your hopes are for future myeloma therapies as a nurse.
Yeah, that is a better quality of life for these patients, because I'm sure there will be there's a lot of hope for better treatment options, but it's much difficult to get a better quality of life. And create a better support system for the patients. I think we need to work more and more with the physicians, and I do see it coming. So I think the hope is that we will work more together, but I'm sure that it will be the future, that patients with multiple myeloma will see also a nurse in the outpatient clinics.
Yeah,
absolutely.
Yeah, and I always also think that we can refer patients more to cancer support centers. And I saw that in the UK you have the Mackey centers. Do I say
we
correctly? Do? Yeah. We also have that in the Netherlands, and it's a great way to find support for the patients and also for the family members, for the children, for partners. So I think we need to more focus on it and inform our patients that there is support for them nearby home.
Absolutely. I actually work right next to the very first Maggie Centre ever to have been created, and now we're international. They are international. So yeah, lots of places looking to get Maggies. There's another third sector group. There we go. We talked about another one in the same podcast. Okay, so are you guys ready for quickfire round? It's not as scary as it sounds. We're just going to ask you some questions. There's 3 questions for you, and really it's just to give us that kind of first thing that comes into your head, that snap answer, just to tell us straight out. We don't want to 5-minute chats about it, or it's literally what's the first thing that comes to your mind when we give you these questions. And I guess I'll start with question number 1, and then we'll just alternate like we have already with the setup today. So Graham, I'm going to put it back to you because you've had a little bit of a rest now. I really want you to tell us, first of all, are there any assumptions about myeloma that you want to challenge?
Yeah, I think we've already said it, but Maaike said it very eloquently. Side effects are not inevitable. If you work as a team, then you can really stop most side effects, or certainly the most severe side effects. So I would say, first assumption, side effects are not inevitable. And if you have a great team, you can avoid them largely.
I think that my catchphrase is going to start being teamwork makes the dream work, because it's at least the second time I've said it. Maaike, what about yourself? Are there any assumptions you want to challenge about myeloma?
Yeah, I did have at the same as Graham, but I do have another one. I think that age is not an issue because it could be an issue, and we need more to get more studies about it. An example is for the transplant patients. We need to find out which elderly patients isn't fit enough for treatment. So it isn't age, it is how fit are those patients. Yeah. And we know that the transplant isn't a problem for the elderly people looking at survival. But what we don't know is the quality of life for the elderly patients after autologous transplantation. And we need to find more about it. So we cannot say easily when you're above 70 years age, it's not a problem to get autologous transplant. We need to get more information about the fitness of those patients.
Yes, absolutely. Older population, etc., etc. Michelle, your question.
Yeah, and just really to echo that, it's about the right treatment for the right patient, which is or the right treatments for the right patients, which is what you guys have been saying throughout the podcast today. So my question, do you have any advice for nurses caring for myeloma patients, particularly for those receiving transplants? And I'll put this to you first, Graham.
Yeah, I think one bit of advice I would say is that because auto transplants tend to run through a hematology unit very smoothly, and often we've got other patients who have more problems, we possibly kind of forget that our myeloma auto transplant is scared, that they may not have enough information. And although an auto transplant is routine for us, it's their only one. And sometimes I think we have to remember that it may be easy for us, but it's not easy for them. And just bear in mind, as we say, that there's a patient there sitting there that may be more nervous than we think.
Yeah, you're absolutely right. We run a telephone follow-up clinic for autologous transplants, and we call them every week for the first 6 to 8 weeks, depending on how they're feeling. And their needs are real, and their needs are at that early stage, particularly after recovery, are not so very different from the needs of somebody who has received an allogeneic transplant. They experience significant fatigue, they have awful appetite and taste changes, they lose weight, they feel frail, they want to know when they're going to feel well again, and that's not so very different from somebody who's received an allogeneic transplant. So I completely agree.
And pre-transplant counselling can come into that, Michelle, because I think sometimes we just think of neutropenic phase in hospital and we forget, as you say, they're tired for 2 or 3 months. They have naps, they find it exhausting. And we need to pre-warn them so that this doesn't feel scary. It's, oh, well, we need support, but this is what they told me to expect and it will get better.
Yeah, completely agree.
Forewarned is forearmed.
Yeah.
I'm full of them today.
Yeah, we see it a lot in I see a lot of patients after autologous transplantation, and I call them lately after 3 or 4 months how they are doing, and they find it so good. They have a moment to talk about the complaints they still have, because it's not only the medication they need to take to the continuous treatment, but it's also the fact that they are tired every day, and they are having problems remembering things and picking up work again and picking up the role in the family they had before, and they think, well, a lot of patients think this isn't normal that I'm feeling this way. No one has told me that this would happen. I would go home and then everything will be fine. I will be getting better. But it won't be getting better in the first 2 or 3 months. It will be getting better in the 6 to 12 months. So we have a big role as nurses to inform patients on that, and just call them several months later how they are doing, and sometimes they need to refer to physical therapy or another support system. So yeah. It is a huge problem for patients after autologous transplantation.
Managing expectations, Managing expectation.
Yeah, exactly. Yeah.
Okay.
Final question, over to you, Emma.
Final question. And it is some months into 2023 already, but we're just going to assume for the next year, what's your hope for the next year in myeloma care? Or in myeloma, or anything to do with myeloma? Graham, what's your hope for just the next 12 months?
Well, I'm going to do 3. Earlier diagnosis for everyone, greater team working, because one of the things Mika said is not just choosing the right regime for the patient, but teamwork means that you'll keep the patient on therapy and adjust it accordingly, because the best teams, anyone can start a regime, is keeping patients on a regime where the real skill is in the myeloma clinic. And then I hope we'll see T-cell engagers and CAR T-cells used widely throughout Europe in the next year.
Fantastic. Maaike, you can have 3 if you want, but if you've just got 1, that's also okay. But what's your hope for the next 12 months in myeloma?
I think that CAR T-cell therapy and bispecific will play a big part of the treatment options for patients. I also think that that brings us to work more and more with all the hospitals around us, because it cannot be just a few hospitals who give those therapies, because it will standard care. So that will be a challenge also, I think, because we need to educate all our colleagues around us. And I also think that what Graham also said, it's important to work as a team, and it will be getting more and more important in the next couple of years, and I think we can do that.
Yes, absolutely.
We're ready for it.
I'm going to need to get badges made. Just teamwork makes the dream work, and just start handing them out at all of our events. And nobody come up to me and look for one of these at our next event. I will not have had them made by the time I'm at the next event. Guys, it's been an absolute pleasure chatting you two today. Thank you very much for joining us. So individually, Graham, wonderful to meet you. Again, congratulations on your appointment with Myeloma UK. Thank you for a fantastic conversation.
Thank you.
And Maaike, it's been lovely to chat to a fellow nurse who feels, I think, the same way that the majority of nurses actually do feel, in that we have a lot we want to do to make that patient journey a bit better. And I think we can do it.
Yeah.
So thank you for being that voice for us today. And it's been a great podcast, and I really look forward to it coming out. And if anybody has any questions for our panel, if you want to get in touch with us via the usual routes, feel free. We will ping them along and hopefully get some answers back for you. But thank you for joining us, guys. It's been wonderful. I don't know if Michelle wants to add anything to the end of my speech.
You said it all, Emma, but thank you. And just one final thanks to you both for your time today. And I think this will be incredibly well received. This is a podcast full of information that people can take away. So thank you so much, Graham, and thank you so much, Maaike, for your time. Thank you.
Thank you.
Well, Emma, wasn't that just a fantastic discussion and chat? Gosh, Graham and Maaike really brought some interesting stuff to the podcast today.
Oh, they really did. There's more things for us to go away and think about, even as the host, co-host of this. So I'm going to give a little summary for our listeners, just some things to think about. And I think one of the biggest, most important messages that both of them gave us, and that we definitely agree with, is that teamwork is vital in terms of looking after patients who have myeloma, because it's not just a one-person job to look after these patients. Graham's obviously very passionate about earlier diagnosis, stopping this being just the disease of older people. And actually, can we find it earlier? Can we detect it earlier? Can we treat it earlier with hopefully more success? They're both obviously very passionate about early detection of side effects, and particularly peripheral neuropathy, which I think we've all struggled with saying today through the podcast. But that, our patients need to be aware that having a sign or a symptom doesn't mean that their treatment is going to end. It means that we maybe not found the most beneficial for them, because they need to have that quality of life. And then, Maaike, with her absolute passion for quality of life in patients, which, I think if we pulled a guest for every type of disease that we treat, every single one of those guests would be passionate about quality of life. It's just lovely to see it from other people as well. I like the fact that Maaike also challenged the age assumption, because a person who is older does not necessarily mean that they are unfit for transplant or unfit for treatment. And maybe we need to start thinking about challenging that kind of just that ceiling as such, that age ceiling that exists, to stop people from being treated to the full capacity of our weaponry.
Selecting patients that are fit, not necessarily based on their chronological age.
Yes.
And also, as we're seeing more patients diagnosed with myeloma at a younger age, let's not forget about those older people when we do that.
I think that cancer treatment in general has moved away from just assuming that if you're an older person, that means it's going to be the thing that ends your life, and it shouldn't be. And I think that that's really reflected in Maaike's work in the chronic malignancies working party as well, because a lot of those patients are living with their disease. It's been great having that first discussion about third sector involvement and groups involvement, and that loved that Maggie's was brought up as well, but Myeloma UK, and hopefully some of our listeners are thinking about who their third sectors are in their countries if they're not from the UK, and using Myeloma UK, who are their third sector groups and how can they come in. And I think that we may obviously now have an idea of what we might want to talk about at some point in the future podcast in terms of those new and exciting novel treatments that we are very excited about, and CAR-T is very much in that sort of headlining news at the moment, but bispecific T-cell engagers and other treatments. So maybe we could find some people to join us on that podcast and break down how those are changing the faces of hematological treatments.
Yeah, lots and lots of stuff to come in the future podcasts.
Yeah, we're not going to run out of topics, are we?
Not at all.
Not at all. Well, thanks again for being my co-host, Michelle. Thank you to everybody who has joined us to listen to this podcast and to previous ones. If you haven't heard the previous ones and you would like to, go to whatever platform it is that you're listening with us today, and you should be able to find all of our previous episodes and our future episodes. They should all be in the same place. And as ever, if you have an idea for the podcast that you would like us to explore, finding guests and having a chat about, please let us know. Please get in contact with us. You can do that via the EBMT website. You can go via the EBMT Nurses Group Twitter account. There'll be a few more that'll be up on the descriptor for the podcast on the EBMT webpage if you are trying to find other ways to contact us. But please do share this with your colleagues, and please get us some ideas and we'll get talking about it. Thank you so much for joining us, and thanks again, Michelle.
Thank you, Emma, and goodbye. See you next time.
Take care.
Bye.